I usually just start going right into a lecture. But today I'd like to say thank you. Thank you for a number of things. One, it's such an absolute pleasure to be here, and it's such an honor. Two is I came down here thinking that I was going to teach. And what I realized by being down here for a number of hours and seeing the hospital, seeing the things that you have, I've learned a tremendous amount. I've learned that there's one thing called vision and another thing called implementation. So kudos to your hospital leadership for really putting on what seems to be a tremendous organization with great growth. Also coming down here is really amazing because it gives me a chance to spend some time with Dr. Tolchin. I'm sure you recognize him. We'll show this a little bit better. This past July, I've been honored to really welcome my 33rd class of new residents into PM&R. And I can honestly tell you that Dr. Tolchin is one of the finest, not only talented physicians, but people. And I think that is what really goes into being a great doc, a great physiatrist, but he's got it. So you're very lucky, and I'm thrilled to be here. My specialty is in spinal cord injury. And I recognize the majority of you are not spinal cord injury specialists. So the learning objectives are in spinal cord injury, and I will take time talking about some of the things, but I really will focus on areas that I'm hoping will be of interest to you, and I'll try to make this of interest to you, but expand it a little bit beyond just spinal cord itself, and really talk about rehabilitation, because this is an in rehabilitation department, and perhaps get into some things about the healthcare environment as well. These are my disclosures. Please know that I do not have any direct financial issues with any of these companies. I have no stake in any of these companies. I just do research in these different areas. So first, I want to introduce you to Victor. Victor was a gifted, talented athlete, a star in the state of New Jersey in basketball, and he was injured in a freak accident where during a rainstorm, a tree fell on him and he became spinal cord injured. I had the opportunity to examine him when he was admitted to our institute. And we talked about some of his fears, his hopes, and his dreams. They included that he would finish high school. He'd be the first in his family to go to college, that he'd get a job, and maybe one day get married and have a family. He asked me about what's new in spinal cord injury. What's the future going to be like for him? And I had the chance to talk to him about it. And I still follow him more than 20 years later. The reason I start by talking about Victor is that as we discuss issues regarding the field of spinal cord medicine or the field of physical medicine rehabilitation or any field, it's important to recognize that it's not about a generic field. It's about people. It's about individuals whose lives, in this case, are overturned to some degree and affected by their spinal cord injury. It's personal. And that this is the way that we need to react to every patient that we may see. Let's take a possible scenario. Sometimes, maybe in the future, or a fall down a flight of stairs, causing a spinal cord injury. Rushed to the hospital, intubated, IV inserted for medications to help with regeneration of the spinal cord and maintain blood pressure.
Yeah, you feeling good?
Yeah.
That's okay. Just if on the people on Zoom, if I can
Great.
ask you,
I feel bad.
If you'd be able to mute, that would be helpful. Thank you. Taken for surgery immediately, because this is believed to be very helpful in allowing for spinal cord decompression and for helping the spinal cord regenerate. Implantation of stem cells, perhaps, and an epidural stimulator, and also placement of an electrode onto the brain for brain-computer interfacing. By day 2, moved into the rehab hospital. All right, this is the future. Moved from one day to the next. The doctors do the examination on me and tell me what my classification is and discuss the modalities and all the different neuroprotective agents that will be used to help me. The therapists tell me about all the things they're going to do, a lot of them based upon my biomarkers or my genetic code, because that's the way treatments will be individualized for patients. Within a few days, I'm started with body weight support, ambulation training, place an exoskeleton device so that I could be walking after therapy, so that therapy is more than 3 hours a day. I start thinking with my brain-computer interfacing about that I want to move some limbs, and with that, can start to move my fingers a little bit. I'm given low doses of oxygen called intermittent hypoxia, which enhances the ability for regeneration of spinal cord tissue. And what's even more amazing is that every single thing that takes place is automatically uploaded from my cell phone directly into the EMR, so that physicians can spend more time diagnosing and treating, as opposed to as opposed to documentation, the time for that. By day 14, start to move my toes on my own. It's super exciting. Everybody is going wild. But it's also the future, and my insurance says it's time to go home at day 14. And so I'm given a home exercise program to do on my own. Day 27, I do a virtual call with my rehabilitation team, and the physician tells me what changes will be made in the treatments. I continue to make progress, and by day 60, I return the exoskeleton device to the rehabilitation hospital. I'm still weak and uncoordinated, but making tremendous progress. And I know that I will continue to get better, but it will continue to take hard work. So is this the future? I've got no idea. But I do know this: the future belongs to those who prepare for it today. And so we need to learn a little bit from the past. We need to really live in the present and deal with what we have today to treat patients as good as we can, but also believe in what the future can bring and be prepared for it. So let's go back into the past a little bit about what the history of spinal cord injury was like. We know from the ancient Egyptian papyrus the talk about, and they called it an ailment not to be treated. There was no treatment, no hope. And this helpless and hopeless attitude really remained for centuries. After World War I, life expectancy in this country was only 1 year with a spinal cord injury. Let's take a look at a video clip from the 1950s about a doctor giving a lecture about spinal cord injury.
Paraplegia is the result of an injury to the spinal cord. That break in the cord causes immediate, lasting paralysis of motion and feeling in the lower body. In general, most paraplegic patients will at various times suffer all of the following symptoms: pain, muscular spasm, dead sores, paralysis of the bladder and bowels. However, all of these may and can be controlled by medical therapy, surgery, proper nutrition, physical rehabilitation, and self-care. Lastly, the question of walking. In almost every case, the word walk must be forgotten. It no longer exists. In short, most paraplegics must content themselves with life in a wheelchair. Make yourselves accept that. It'll make it a lot easier.
Now, I'm not saying that that's the way we should be talking to patients and families, obviously, but this is a true movie that was made. It was a docudrama. People have always asked questions, but what about the future? What is there in research available to us? And in that movie, that's exactly what took place. And listen to the response.
This condition, there must be some cure.
It's just a death sentence. I'm happy to say that in most hospitals, the mortality rate has been less than 3%.
I didn't mean that. I meant the spine injury. Surely there must be some way of healing it. There must be specialists somewhere.
Well, there is no method known to medical science for the regeneration of spinal cord.
So this was 1954. Do you think things have changed when people ask about the current spinal cord injury research that's available today? The answer is that while the field of spinal cord medicine was once known as a field of doom and gloom, there is so much taking place right now. And, there's lists and lists of all the different studies that are taking place. We are not going to spend the next 40 minutes going through all of these, but I did want to go over a couple of topics that I thought may be of interest to you, most especially because they're the issues that most people call me about to say, what do you think about this? This was on the news. What do you think? So the first, because I heard that there'd be a couple of surgeons in, I wanted to update regarding spinal surgery after acute spinal cord injury. Surgical decompression has become a cornerstone of management of patients with acute spinal cord injury. But the influence of the timing of surgery has really been controversial. In recent years, towards the end of the 2017, a couple of articles, including consensus guidelines, came out that described that early surgery should take place within 24 hours. But if you look at the data and you look at the quality of the evidence, they were very clear. Quality of the evidence was low and strength of the recommendation was weak. So that was 2017. So it's now 2022. So what's taken place since 2017? So newer studies really have shown greater evidence to show that early surgery is helpful. In terms of, and really synthesizing all the literature into one slide, I'll summarize it as follows. Early surgery, meaning within 24 hours, there's now moderate evidence, which is an improvement from low quality evidence, that early surgery is associated with increased motor scores. How much? 4 points. So if we take a look at a 100-point scale, 4 points, and it was a significant difference. In terms of ASIA impairments, which is the severity of the spinal cord injury, early surgery does help with people that convert from complete to incomplete injuries. So these are all positives. There is no definite impact on length of stay. That's because length of stay is really shortening so much for everybody that there's no longer a statistical difference. And the severity and level of injury doesn't seem to impact it either. So while in the, I would say 5 years ago, more people thought that cervical level was more beneficial from early surgery as opposed to thoracic, now there is evidence that maybe even with thoracic injuries, the earlier you get to it, the better. Now, the one question that sometimes surgeons will ask me about is, what about central cord syndrome? When do you operate on those? And obviously I'm not a surgeon, and so I can't tell surgeons what they should or shouldn't be doing, and they know their literature. But I would answer two questions, and certainly, by the way, I'm throwing things out there that hopefully there'll be questions about. We can talk more in detail. The theory of central cord syndrome that everyone taught is wrong. Central cord syndrome has nothing to do with where the tracts are located. I know that's what people used to be taught, and that a lot of people used to deal with central cord syndrome differently than others with incomplete spinal cord injuries, especially incomplete tetraplegia. The feeling now by many is that you treat people with central cord similar to other incomplete injuries. and also based upon the age and medical comorbidities, you make a decision based upon that, as opposed to just whether they're called central cord or not. And certainly I could talk about that more in detail. Now, if less than 24 hours works, what about earlier, right? What about 4 hours or 8 hours or 12 hours? Is the earlier the better? And the answer is, if you look at the literature, that there's really no firm conclusion that that's the case. Even though there are some studies that say yes, other studies say no. But we have to keep in mind that the problem with early surgery is that it's an early evaluation. And the early evaluation is not very good in a number of cases. And I'm happy to speak to people about the different articles that talk about this. But right now, there is no strong evidence to suggest that you got to get in within 4 hours or 8 hours. Within 24 hours is still considered best. Now we'll go through a couple of newer interventional trials that are currently ongoing now. I realize that they're not going on here at this point, but you may be asked about them depending upon the type of work that you do, but I'll only spend a couple of minutes on them till I get to the rehabilitation aspects. This is called the Mitsubishi trial. The Mitsubishi trial is an antibody that prevents secondary damage, and it works in different parts of the spinal cord. It's a phase 2 study. It's 72 patients are to be enrolled. It's currently enrolling individuals with cervical level injuries, C4 to C7, with different severities of injury, IV infusion. So that's a good thing is that it doesn't necessarily need surgical intervention within 48 hours. So you have to be injured at a site that they're doing this trial. So this is currently ongoing, and I should say that we are involved in this trial. This is a trial that has really gained a tremendous amount of interest, especially from surgeons, although across the board, anyone that's doing this type of work, because of how unique and innovative that it is. It's called the INSPIRE study, which is a very nice name, certainly a very inspirational name. And it's a pilot study specifically for people with acute thoracic spinal cord injury. And what they do is they insert a biodegradable neurospinal scaffold, which allows and supports appositional healing. So think of it as a bridge. If you want the two ends of the spinal cord to know where to connect, you need something that will help them connect, will tell it where to go. So that is what this is, and biodegradable, that in a short period of time, over a course of weeks, it will self-degrade, and that by that time that the bridge will already be formed to help with the patients. 2 articles have been published in the last year that discuss this. And the results of this is that, unfortunately, in the beginning, there were 3 deaths. Because of the 3 deaths, the study was halted for a little while, but then it was allowed to proceed. And of the 16 people, a higher percent, 43% of the patients converted to incomplete status. Since that number is a little higher than general population, this study will most likely go on into the next phase of its trials. The next study is a really interesting project, and we're not going to get into the specifics of what Rho inhibition is. Just know that this is a drug that is presumed to be used that can decrease the secondary damage after a spinal cord injury. But what's unique about this is that unlike other surgical interventions, you don't need to inject anything into the cord. You put something on the cord by using a fibrin sealant. So you could just put it on the cord itself. It will be absorbed by the cord, and hopefully that it would enhance regeneration. Unfortunately, they did a interim analysis and found that there was no benefit from it. So this study has been halted. But the idea of potentially using fibrin sealant and letting things be absorbed is certainly of continued interest. I can't tell you how many calls I've received in the last couple of months about the NerveGen trial. NerveGen is another type of class of medications, of molecules that will enhance regeneration. This is one of the few drugs that have been studied in the animal model that is now moved to human studies that has a tremendous amount of excitement. but people should know that it is not yet started. People are thinking, so many calls, why aren't you doing it yet? Where is it taking place? I want to sign up for it. It's only going to be studied at one center right now. It's sub-Q injections in both acute and chronic injury. It should start sometime later this year. And I'll just mention real quickly about an AbbVie study that it's also on interventions within 24 hours of injury. But I think that if you were to take a summary of all the surgical and pharmacological research in spinal cord injury, there are a couple of things that you can find. Notwithstanding, so this I found that just appeared, it says July 13th, so just a couple of days ago, and every week there's another article that shows that there's a new something that will be the cure-all for spinal cord injury. This one says cancer drug candidate helps regenerate nerves after spinal cord injury. I took one of the tamer ones. Usually it's new cure for spinal cord injury coming. I think the reality is that after 30 years of study, there's still no FDA-approved treatment for acute spinal cord injury. Heck, people are still debating whether to use steroids or not. And that's an argument we can talk about the pros and the cons. And it was a really interesting article that appeared a decade ago, which basically said a century of research focused on the lesion site has been unproductive. An alternative field of research is needed. So the question that so many people, and I meet with patients and families every 6 weeks. We have open forum. We do it now virtually because since COVID, where it's an open forum, people can ask me any question they want about research in spinal cord injury. And one of the most common questions people ask is, why is it so hard? How many times do they find rats that can walk in studies? Why can't they get humans to work? And I think it's really important to understand the difference between the animal model and the human model. And by the way, I'm not saying anything negative about the tremendous work that basic science researchers are doing. It's critically important. But we have to also understand some of the limitations. First that I'll say is that there's a true heterogeneity in spinal cord injury. We label people by the severity of their injury. And as someone who spearheaded the international standards for classification of spinal cord injury for many years, I love the importance of the classification, but people misunderstand parts of the classification. If I were to show you this MRI, I don't think you need to be a neuroradiologist to be able to say, these injuries don't look alike, right? The lesion on the left is so severely impacted of the cord, but on the right, it's really not. But yet both patients on examination were Asia Impairment Scale A. So if I'm doing a research on both patients, and I want to see if a drug works on an Asia Impairment Scale A patient, well, which one am I going to be doing? Because for most of these studies, not all, MRI is not an inclusion criteria except for non-contiguous injuries. So clearly these two patients aren't similar. When it comes to the animal model, right, you use the same animal, the same age, the same sex, the same exact type of lesion, the same post-op care, but that's not the way that it works in humans. Everyone's different. The patients that come in, they're different ages. Some are young, some are diabetic. We know that will play a role. Some are smokers, some are hypertensive, and they all have different types of injuries. So we can't just sort of randomize patients and say that, okay, well, because we randomize that they're equal. We have to also understand that the basics of the nervous system is different. In the rat model, for example, the net weight of the spinal cord is 30% of the central nervous system. Yet in the human, it makes up 3%. You have so many more fibers that interact with the spinal cord in the humans than you do in the rat. And the tracts are completely in different places, right? The corticospinal tract in the animal model is medially located. It's laterally located in the humans. And so I like to tell people is that while we all want a cure, everyone wants a cure. There is no doubt. What we currently have is hope, research, and rehabilitation. And this is what many of you do. So I'm going to go through a couple of the rehabilitation interventions that are currently taking place. I'm going to keep an eye on the time to make sure that we don't go over time. And I will talk about some of these things and to share some of the excitement with you about things that are taking place. But I also want to remind people, and I'll do it again, that we only can't think about rehabilitation in terms of these new and exciting things, but let's not forget the old time things that really work. Just spending time and understanding what's going on with the patients. So let's start with body weight support treadmill training. Again, maybe I'll be a little bit, create a little bit of a stir so that we have some conversation, but it's been more than 30 years that people suggested that body weight support treadmill training is going to be effective in rehabilitation. This created a tremendous amount of excitement within the field. We found something that's really going to make the difference in patients. I think that if you were to take a look at all the literature, you'll see that this is a great review that was made, that they looked at the different articles. Some showed positive, some showed negative. Those that showed positive, the treatment effect for enhancing walking is less than 0.04 meters per second. So it's not that much of a big difference. Now, and the quote here is, compared with conventional physical interventions, no significant effect of activity-based rehabilitation on lower limb mobility, independence, or quality of life. Now, there are other studies that were not included in that 2017 paper. That included, right, there was a great paper by Morrison and their group. It was a multi-center trial that showed that activity-based therapies was really very helpful in patients. And sometimes it took up to 100, people were making gains for up to 80 sessions, even up to 120 sessions. So I want to be very clear. I am not suggesting in any way that walking therapy is not helpful for patients. It absolutely is. The question becomes, is activity-based therapy program better at neurologic recovery or walking recovery over time, as opposed to, let's say, manual therapy or physical therapy? And the answer seems to be no. Again, that doesn't mean that walking isn't critically important. It is. And there may be benefits of activity-based therapies and bodyweight support treadmill training for therapists, et cetera, in terms of their workload. But in terms of whether it creates neurological benefits, right now, the answer is no. Acute intermittent hypoxia is fascinating. This is work that we're involved in doing with as well. And it's where there's neuroplasticity that's activated by modest hypoxia. Now, this is something that you should not be doing at home, and you shouldn't be doing it with your patients saying, okay, hold your breath for 5 minutes. This is very specific intermittent hypoxia. It's very small time periods of about 9 to 10% oxygen, and you get enhancement of nerve regeneration. It is amazing. This does come from the animal model, which is now proven to be used in humans. It improves strength, endurance, walking speed. A number of different studies have looked at this in all these different areas. We have a study, a collaborative study on upper extremity. It works fast. This is amazing. We can tell before the person even joins the study, we give them one trial. And if they show improvement, they're in the trial. If not, then we don't. Some people are either responders or they're not responders. It's relatively easy to implement. It's low cost. I think it's important to remember, and I'll say this once, but it goes across all the different interventions. Intermittent hypoxia or anything else doesn't work unless you're doing rehabilitation. All of these interventions are the primer. We were talking with Dr. Durrett earlier, and I'm not making a joke at all about it, but we're talking about painting. So this analogy comes to mind. The first time you put paint on, you put the primer on, and then you have to do the painting. You don't leave the primer on. The intervention, and in this case, the intermittent hypoxia, is the primer. that allows then the rehabilitation to take effect. So it's one doesn't replace the other. Fascinating that seems to, for those of you that like caffeine, that pre-caffeinating seems to, before they get intermittent hypoxia, seems to help. And that's because of the mechanisms that it works within the serotonergic pathways. So that's really interesting. And what's currently trying to be figured out is, okay, what is the right dosage? Because too much hypoxia is bad, right? It can give you cognitive side effects. It can give other side effects. So figuring out the dosaging without side effects is critical. Okay, exoskeletons. I promised that I would cover exoskeletons. There are a number of different exoskeletons available now on the market. The most common one's the ExoGT, and here's a video of a patient in our lab. We do use the Exo, the Indigo, the Rewalk. Both the Indigo and the Rewalk are available for home use. The Exo is available for rehabilitation centers alone. And it's really pretty easy for patients to really get up and walk, depending upon the level of injury we'll talk about in a second. This is overseas, not in America, but overseas in Europe. The Rewalk is available to be used for stair negotiation. So this is the future of exoskeleton devices. The literature on exoskeletons, there was an excellent review article that was published this past year. They showed that for some of them, they can use in higher levels, but in most cases, most studies have used the Exo, Rewalk, and Indigo. Most level is a T6. Although some you can use higher. I certainly have gone higher with some of these patients, although they're not approved for home use at lower levels of injury. What's unbelievable is that not only you see in this slide that walking is an outcome measure, but look at all the other aspects that are being studied as well. So the ability to get up and walk can have dramatic impact not only on ambulation and mobility, but also on aspects of cardiovascular, bowel, bladder, spasticity, and pain. So a lot more research hopefully will come out regarding this. Now, people have asked me, well, how fast can you really go in these exoskeleton devices? So on average, the studies have shown that you can go about 0.31 meters per second, which is about 0.7 miles per hour. The fastest one person has gone is 0.83 meters per second, which is 1.8 miles per hour. So the average elderly person, again, the definition of elderly, we were sort of joking about this last night. What does elderly mean? The correct answer was not 35. But if you take the average 80-year-old, they're walking at about 2 miles per hour. Anyway, there's a disagreement, 1.8 to 2.2 miles per hour. So that's not bad for an exoskeleton, but the patient that can do that at 1.8 with the exoskeleton was a very low level injury. So the ability to maintain safety, but also speed is going to be important. Brain-computer interfacing is another really exciting area. This is the idea where a thought can get translated into control of either a robot or a muscle or some sort of activity. And think about it, though. When you want to reach for something, if I wanted to get that microphone, really what I'm doing is I'm thinking about it. The messages are going from my brain, down my spinal cord, to my arms, well, first to my legs, to take the step or two that I need to grab onto the microphone. This person with spinal cord injury has the exact same interest. The same electrical activity that's taking place in the brain, that's what it is, it's electrical activity in the brain, but the messages can't get through the damaged spinal cord. So what brain-computer interfacing does is it interprets the electrical information from the brain, and then the information is then translated and then could be sent to a motorized device or something, a robot. This is an example. Let's see if this video works. This is from University of Pittsburgh, which took place a while ago. So this is the person's thinking. You can see the pedestal coming out of the person's head and being able to, her thought is able to grab the robot to bring the chocolate to her mouth. This was a study that was published not too long ago. down in Florida, University of Miami, looked at implantable brain-computer interfacing that controlled the motorized hand orthosis. You can see it in the picture. And that allowed for the person to pick up headphones or pick up a brush. So this is really exciting work that I think a lot of people are looking to get into, and certainly seeing the vast neurosurgical capabilities here, I would imagine that this is something in the future that you'll be looking into as well. But the future is beyond just this idea. Because, and this schematic will show it. Right now, the idea is that you could take the brain signals and trigger some sort of either robotic control or motorized control or electrodes in the hands. But I think that the future really will be is to take these thoughts and reconnect it to the right areas of the spinal cord so that you just bypass that damaged area of the spinal cord so that the thoughts can then go right to the spinal cord. And certainly this is part of what is in some of these robotic exoskeleton devices are set up to do as well. The last rehab aspect that I want to talk about is spinal stimulation. And there are two types of spinal stimulation. There's epidural stimulation and transcutaneous. Epidural is where you implant and you place it on the spinal cord itself, whereas transcutaneous is through the skin. Now, the traditional way that we think about spinal cord injury is that the brain is in control. The brain controls everything, and just the spinal cord is the relay messenger down to the areas. But that really doesn't seem to be the correct way of thinking about it, that the spinal cord really has the ability to think or to control things on its own in some ways. And I'll see if this video is working. So this is a person starting to walk when the transmitter is on, the stimulator is on, and then when you shut it off, it will stop. So what happens? I couldn't get the right video to work in this case, but what happens is that the spinal cord stimulation, it bombards the spinal cord with trying to let the message get through. In most cases of spinal cord injury, the spinal cord is not severed. The spinal cord is bruised. And we know from medical school back that if there's delays in the messages going through the nerves, that it doesn't go through. And the thought is that by spinal cord stimulation, you're giving it so many impulses that you're finally allowing the messages to get through the spinal cord. Spinal stimulation itself doesn't induce stepping, for example. It enables it because that's what the brain says that it wants to do. But the spinal stimulation now lets the information get through to the spinal cord. This is a patient of ours who was receiving transcutaneous stimulation. I'm going to switch off. So this, you can see that he's on a body weight support system, really protect the therapist as well. He couldn't move. And with some spinal cord stimulation, he's now able to control himself better. Now, you'll argue appropriately saying, well, he's certainly not independent in walking yet. And you'd be correct. But this is a patient 8 years post-injury who and he underwent, before he started this, he underwent lots of therapy. So it's not the therapy alone, but it's the bombarding the spinal cord with information that's now allowing it to get further to help him move. This is another patient of ours. This is a person of C5 level injury, who you can see cannot grab the bottle of water. It's supposed to be water. And then after 16 sessions of transcutaneous stimulation, you can see he can now pour the water into the glass. That's Janelle, who's our OT, one of our OT therapists, researchers. Now, the interesting story about this one is that we were all really excited. Dr. Gail Forrest is the director of our program. I'm the co-director. We were all really excited. And the patient was pretty happy. But we thought the patient would be even happier. And so we asked the patient, why weren't you as excited as we were? And he said, I'd never dreamed about pouring a glass of water into a cup. That wasn't my dream. So I said, what was your dream? And he said, well, I'd love to have a catch with my son. So he said, okay, that's it. It wasn't in the IRB proposal, but okay, let's get it into the IRB proposal. And we now then taught him how to hold the ball and throw a ball. And he was able to do it. So we did achieve, so we made him happy too, right? Does it make everybody happy? That's the goal. Now, there's been a number, we were just talking with Dr. McDermott right before about the great article in Lancet. There are a number of centers around the country, around the world, I should say, not just country, the Cortine Lab, the Harkema Lab, the Dr. Darrow's lab, so we have Mayo Clinic, University of Minnesota, a couple of places that have really done a great job of showing that people with epidural stimulation can walk. Each of the labs do things a little bit differently, and I'm happy to talk to you about the little bit of different things that they do with their studies. There is no doubt that this is a major breakthrough. No doubt. But I think that it's important to recognize that it's not only about walking. When I ask my patients, what is it they want? Yes, after a spinal cord injury, they're going to say, I want to walk. But ask them a few years later what they want. And they'll tell you, Doc, I want to be able to control my bowel, my bladder, my spasticity, my pain. My gosh, how much pain is there in people with spinal cord injury? They talk about what's called the hidden disabilities. The idea of their blood pressure dropping throughout the day, they just become so hypotensive. One patient explained to me, he says, Doc, I feel every day like I'm waking up and I've got the flu, minus the coughing and the sneezing. I just can't get into the day. It takes me hours to get into my day. And what's amazing is that these interventions of transcutaneous and epidural stimulation is being studied on these areas and are being very helpful. So remember that rehabilitation is critical. In that article, it was really quite interesting. Dr. McDermott had mentioned that it's a 46-page article, which is correct. It's not a quick read, but you'll notice in the article they talked about one of the highlights was that the patient improved immediately. But then if you read the article, that most of the outcomes was after the person had significant amount of rehabilitation. Rehabilitation is critical, but there's still much work to be done. I'm really thrilled. If anyone back home was to see this, they'd get mad at me if I didn't give a little marketing. The other day, we just got word that our collaboration with Louisville, Medtronic, and Hopkins, we were the first round winners of a Neuromod prize. So there's 8 centers that get a prize for their innovation or ideas. And the idea is that it's a neuromodulation of the lumbospinal cord, but that could interact and go between regulating multiple different organ systems simultaneously. So it's not one or the other, but because of this idea that there's so many different organ systems being affected by spinal cord injury to enhance their capabilities in many different areas. There's so much going on. I wish I can describe all of them to you. But I wanted to just now share with you some of my personal thoughts regarding spinal cord injury as a model of where we are with rehabilitation, because this is a rehabilitation lecture as well. We've come a long way in so many different ways in rehabilitation and spinal cord injury, and certainly I list on the slide for you all the different things that we have. And in the course of my own career, I've seen things change. When I was young, I had the opportunity, and this, I'm not giving away anything HIPAA, certainly this was in many things that Christopher Reeve wrote. He was a famous actor who got injured. He had a very high level spinal cord injury. He was ventilator dependent. And he talked about his dream of regaining the ability to walk. And not only did he dream about it, he talked about that it was going to be a reality. And I will tell you that he caused a stir because of his promises that it would. That not only did he take a lot of heat, I got a lot of heat. People would say, well, you're enabling him to say those things, as if we can control what our patients think. And I think that his commercial at the Super Bowl, which most of you may never have seen, but I want to show you a brief clip of his commercial from the early part of 2000.
And in the years since the new millennium, the world has seen such progress. In 2004, the tide was turned against AIDS. 2 years later, great strides against cancer. And tonight we celebrate a remarkable breakthrough in spinal cord injuries, made possible by countless researchers and contributors. And to present this award, we have some very special guests.
The criticisms were unbelievable. The great, brilliant Charles Krautheimer, I don't know if people knew that he himself was high-level spinal cord injury. And what an amazing individual. I had the chance to meet with him a number of times, but he really criticized him severely. We don't have time to go into some of the things that he wrote. But I will say that Christopher Reed's dream, even though he passed away, didn't stop. And didn't stop people from wanting to do better for patients. Over the course of my career, and it's interesting, I'm joking, we were talking last night, I had a great chance to meet with people. And I did a podcast a few weeks ago, and the person asked me saying, now that you're at the end of your career, what suggestions do you have? And I interrupted the person, I said, who said I was at the end of my career? I didn't think that I was, but over the course of time, I've seen so many different changes. And I think that the biggest change that I've seen in spinal cord injury is the dogma. The dogma of that the spinal cord can't recover. We now know that's not true. The early time post-injury is the only time that recovery could be expected. That's not true. There are patients that have been injured for 20, 30 years now who are undergoing some of these interventions that are starting to make improvement. And this idea that people can't walk again, while not as good as they'd like to, and certainly not as good as we would want them to, but it's changing. So final thoughts. It was really great last night to spend some time with physiatrists of all different age groups, and I want to express appreciation to Dr. Tulchin for arranging it and for the people who were there. But it was great to see people who are so engaged in rehabilitation. I recognize the thrills that I had when I went into it and continue to see amazing things taking place. And it's sort of what energizes me day to day. It's why I still love to see patients, although administration thinks I see too many patients. I think I still don't see enough patients, but okay, that's the way life goes. But you see amazing things happening in the gyms, on the floors. And you say, wow. Rehabilitation is really unbelievable. And you think about what does rehabilitation mean? The Latin is to make able. Now, we're not the only ones. We don't have a monopoly on making people able, but we have a niche in there. People in rehabilitation and physiatry, the therapies, all people involved in it. We're able to make people better. And what a difference in their lives that it makes. And as I look towards the future, there's no doubt that we've come a long way, but that we also have some significant challenges that we have to face that are reality. And these are challenges that our patients face, their families face, and we as advocates for them are facing as well. And we don't have time to talk about a lot of these, but I'll just spend a couple of minutes. One is this idea that rehabilitation is all about technology. There are so many cool things out there. Let's get the latest in this, the latest in that. Yes, that's true. But that's not what rehabilitation is all about. We utilize innovative and novel technologies to enhance what we do. And we can't forget the tools and the goals of what rehabilitation is all about. We have some issues that are real. And we're not alone. This is healthcare, right? But we know from rehabilitation itself that what the changes are in terms of allowing people to go for rehabilitation services. This idea of Medicare Advantage, right? I'm not getting political in any way, but I'm just quoting from medical journals, from the New York Times. If you are part of general, fee-for-service Medicare, you have a 4.4 times chance of getting approved for rehabilitation services than if you have Medicare Advantage. Well, this is a problem. Early rehab, we know, is beneficial for patients with spinal cord and other things, but it's being denied. In some states, you can't get rehab if you have state funding. Length of stays are being shortened. I joked about 14 days, but I'm not sure that it's such a joke. What good is the world's best healthcare if you're not free to use it? Equipment, we discussed last night. We don't have time to talk about this, but this is, I had a patient denied their wheelchair. And so I looked online to try to get some help. And this was from this is serious, where the insurance company denied the wheelchair for a patient with paraplegia because the insurance company wanted an article within 5 years that proves that the wheelchair is beneficial. And that if you couldn't produce an article within 5 years, I mean, this is unbelievable. Unfortunately, the amount of rehabilitation offered to people affected by disabling conditions is diminishing. People making the decisions may not fully understand the value of what rehabilitation can accomplish and the impact that it has. And I think it's because value changes based upon perspective, right? And the circumstance. To those people with spinal cord injury or with other conditions that need rehabilitation services, the need is tremendous. But the people that may not understand, who may only be looking about approving or not, are different. And I think those of us in rehabilitation need to understand that there's a role for us to play. We can choose to be in healthcare, what I would say is the thermostat or thermometer. Or we're just going to simply gauge what's happening out there and say, okay, that's what the temperature is like. We're going to have to deal with it. Or are we going to try to set that gauge to say, no, we're going to advocate back for people, not for us ourselves only, but it's for the people that need these services. And that's where rehabilitation and all of healthcare needs to continue to advocate for the people that really need the help. So we've come a long way. There is no doubt. I agree. I believe we're on the road to recovery. Gosh, we can see the cord better than we've ever been able to see it before. But honestly, I have no idea where on this long and winding road we are. I can't tell you that we're at the peak. We're certainly a lot further than we were when I started this and 10 years ago, but there's a way to go. Remember that for people with spinal cord injury, though, it's not only spinal cord, it's for all the things that you may see. It's not only about the future and the cure, it's about today, right? They have lives to live just like all of us do. They've got families, they got work, they got potential, they have fun things they want to get to and they want to do. And it goes beyond just technology. And this is what rehabilitation does. Rehabilitation is a critical part of every aspect of functional and neurological recovery, and clearly a crucial part of any cure strategy. The rehabilitation teams help people remain healthy, remain strong, and gain to where they need to go. We need to be committed to them and their future as well. We have to remember that we're dealing with people who need our help. And every interaction, giving a person just another couple of seconds of listening to them, and sometimes just giving them a voice of concern, of compassion, can make all the difference. And walking through your halls of the Cancer Institute, which we had a great tour, made me realize what a great job you're already doing, and I can imagine that you're doing it in many other areas. And this is one of my favorite slides, and I mentioned to Ivy earlier. Our doctors don't just come and mend the broken bones, but they stay and mend the broken spirits. There's more that we do than just simply the toxin injection or the EMG, nothing wrong with EMGs. I know you do a great job, but all the other things. But it's spending that extra just minute, just giving them the time. And I think that they'll really appreciate it. So what about Victor? I continue to see Victor, and it's really unbelievable. Things have changed. He continues to ask me about what's new in spinal cord injury, and I continue to discuss it with him. But what's new with him is that this was his wedding. This is his child, who's now 1.5 years old. So as I look to the future, I really believe that in the strength of the past, we've all built a vision for the future. I wish you all the very best. And once again, thank you so much for inviting me down here. Have a good afternoon.